Want to know about taking a selfie of your insides? Stay tuned and I'll tell you about imaging the heart. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Today I'd like to talk about how we take pictures of your heart. What does that mean for you and what's the science behind it? Hi, I'm Dr. Warwick Bishop and welcome to the Healthy Heart Network. Well, how can we image your heart? There are lots of different ways. We can take an electrical image. This is called an ECG, or an electrical picture. We can use a chest x-ray. You can see the heart here in the middle of the chest. We can also use ultrasound, which gives us pictures using bounced sound waves, just like we use for looking at a baby in a mummy's tummy. We can inject contrast, dye, directly into the arteries of the heart and outline the arteries of the heart with an invasive coronary angiogram. We can take MRI images of the heart. And MRI is magnetic resonance imaging, a different form of evaluation. In our circles, we call it CMR, cardiac magnetic resonance. Lastly, we can do CT of the heart to outline arteries and give us an appreciation of structure as well. Beautiful anatomical images. My brief today is to talk about CT, but before doing that, I'd like to give you some background. When plaque forms in a coronary artery, there is movement of cholesterol into the artery wall. That cholesterol can accumulate. If it does accumulate, then special cells, which are garbage cleaners of the circulation, move into where the plaque is. Those garbage cells, which we call macrophages, gobble up some of the cholesterol, but unfortunately, they swell up and can die in location in the wall of the artery. As they die, they burst and release some of the enzymes. This is at a microscopic level. Those enzymes released lead to areas of microcalcification, which is from scarring forming and calcium within the circulation settling on that scarring and giving rise to focal spots, little areas of calcium within the coronary arteries. Now, it's really important you understand that calcium can be part of a plaque because that's one of the things we look at. Back in the 1930s, there was a German called Lenk who, with X-rays, was able to observe calcium in arteries. In 1959, a US group actually took X-rays of cadavers to confirm that calcium could be seen in arteries. But in 1968, a group of researchers led by a Dr. Maguire used X-ray, special X-ray, to image the hearts of people looking for calcium. They were able to image 100 people and compare the characteristics of those 100 people who had calcium versus people who didn't have calcium. And this is a summary of their results. This is the results of the no calcium group. This is the results of the calcium or calcification present group. No symptoms is in green and no symptoms is better. So the no calcification group had more green, more no symptoms. Myocardial infarction is in blue. This is bad. So the more blue, the worse it is. The people with calcification clearly had more myocardial infarction. Or the word we use is myocardial infarction. You're familiar with it as a heart attack. So from early days, over 50 years ago, it was very clear that having calcium in your arteries wasn't necessarily a good thing. And although we didn't really use that information for many years to come, it was a sign of things that were to come in the future. It really was an opportunity to look at someone's heart and get a feel for their risk. In the 1980s, technology changed and there was development of a special scanner called an electron beam tomography scanner. And this is a special type of CT scanner which allows us to sweep very quickly through the heart and acquire images. Remember, the heart moves at about 70 beats per minute. So it's a really hard thing to take a picture of because it's beating just about every second. The electron beam tomography, though, allowed us for the first time to have a rapid acquisition of images so that we could look for calcification in a reproducible and accurate way. This technology was used for the first time in a structured way by someone called Dr. Arthur Agatston. And he generated a scoring system which we still use today based on the amount of calcium we see in the arteries. In the mid-90s, a pathologist called Rumberger actually published a paper confirming that calcium is closely linked with the development of plaque and cholesterol within the arteries. It's really important to understand as I go through this that calcium is not what kills people. Lots of my patients want to know, is the calcium the problem? And I like to let them know that calcium isn't of its own the problem, it is a marker. And the way I try to describe that is I say, look, if you were going to pitch a tent in the jungle, you'd look for somewhere where there's no tiger footprints. The tiger footprints being the calcification. So if you pitch your tent in the jungle where there's no tiger footprints, you might be at low risk of being eaten by a tiger. If you pitch your tent in the jungle where there's lots of tiger footprints, you might be at high risk of being eaten by a tiger. But either way, the footprints, the calcium, are not what's going to kill you. Around 2005, improved technology meant that gantry-type CT scanners, the most common sort of CT scanner we see, became faster and faster. And in fact, they became so clever they could time their image acquisition with the beating of the heart. This was allowing us an opportunity we hadn't had before to get reliable, reproducible images of a beating heart in a living subject. So now we have a way to look at the arteries, and it's becoming more and more widely available. This is what a CT scanner looks like. There's a scanning bed and the acquisition rotating X-ray heads. These are the sort of images we acquire. We call this a non-contrast scan. You can see the heart in the middle of the chest. You can see little white spots here that are not there. This is calcification. No calcification here, plenty of calcification here. You don't need a lot of training to see that. So this is absolutely fantastic, and it gives us an opportunity to start to understand what's going on in someone's heart before they have a problem. We can do even better than this though. Our modern technology has progressed in such a way that we can inject contrast into the arm, just into a vein while someone comes in to have this scanning, and bring out these incredible images which not only show us calcium but start to show us the inside of the coronary arteries. They show us the size, the composition of plaque, the location of plaque within the artery. We get exquisite images that allow us to be so precise about what's going on. We can start to make some really significant choices and decisions around a patient's care. I won't go through this, but this is a snapshot of the sort of workstation we use to pull all that information together. We can straighten arteries out, we can measure narrowings, we can rotate through arteries. We get 3D images that we can rotate and look at, and standard axial views, which are the slices through the heart. So I'd like you to take away a couple of points. There are different ways to look at the heart, and of course we use those different ways for different reasons. Calcium has been observed in the coronary arteries since the late 60s, and it's been understood that it is a marker of a worse outcome. It's taken a while, but technology now means that our CT imaging has evolved to a situation where it is more and more widely available and can accurately and reproducibly evaluate what's going on within the arteries. Lastly, by adding contrast to CT images, we can see exquisite detail previously completely unimaginable to obtain in the living subject. And think of the power that that gives us in terms of knowing what to do for you or the individual we're dealing with. Stay tuned for Alan, a sheep farmer with his own story. So you've just heard all about imaging the heart, but now I'm going to move into our case for this episode. Let me tell you about Alan, who is a 76-year-old married farmer who was active on his sheep and hay property. Obviously, he lived a fair way out of town, but he came in one night with chest pain. That chest pain was certainly potentially suggestive of heart disease, and he did all the right things presenting to accident and emergency. They did blood tests and they did ECGs. It turns out that the blood tests were normal and the ECG showed no changes. Although Alan was 76, he was in good health. He was on no regular medications and really considered to be at relatively low risk in the scheme of his cardiovascular risk assessment. Let me show you what his risk assessment profile was like. We've got his age and sex, blood pressure, cholesterol levels, obviously not a smoker, and his risk of an event was 12% in 5 years. He gets a yellow thermometer for this, and the yellow thermometer really indicates that probably could or needn't necessarily have therapy, not a major driver. In fact, I was pretty keen to consider therapy for this gentleman, but he was a little bit apprehensive and said he'd really rather not take medication unless it was absolutely required. We did put him on a treadmill test, and this showed that he exercised very well without any problems whatsoever. We discussed imaging his heart just to be clear about whether there was any rust in the pipes, any plaque that was not causing any narrowing, and this is what we saw. Without question, there was calcification that was easily seen throughout his coronary tree. And importantly, you can see there's a suggestion that the blood would flow through that without too much of a problem, and that would be consistent with the treadmill test not showing any narrowing. So this gentleman had plenty of rust in the pipes. In fact, his calcium score was about 1,500, which is really high in absolute terms. And for a man of his age, really high as well. However, no flow limitations, so no symptoms, and without taking a picture, we would never have known what risk he really may have had. We did get to put management strategies in place based on this information. Because of his high calcium score and because of these findings, there's no question that his risk left unattended would have been unacceptably high into the future. We commenced appropriate cholesterol lowering tablet. We also included aspirin, and we followed up on blood pressure. We're keeping a close eye on him now, and he's still tending his sheep and producing hay. Stay tuned for our patient questions section, which is coming right up. Welcome back. This question and answer section is about calcium supplementation. I see plenty of patients who regularly ask, should I be on a calcium supplement or not? Particularly since we talk such a lot about calcium in the arteries. Often patients are already taking something, maybe a calcium supplement or maybe some vitamin D, and they're concerned about whether or not they should continue. To a degree, the jury is still out on this a little. There is inconclusive data in relation to supplementation and coronary calcification, though there is some literature that is suggestive that high levels of calcium taken in the inorganic form, so by tablets, may be contributory to increased calcification in the arteries. My general recommendation, however, is that if there are significant issues with the bones, thin bones or a condition called osteoporosis, such that supplementation is indicated, then it should certainly be considered and used based on the best advice of a specialist in that field. If there are no clear issues with the bones, I suggest that patients obtain their vitamin D through sun exposure. Of course, not getting burnt. People who take supplements need to be aware there is no naturally occurring oral form of vitamin D. And remember, some oral dosages can lead to levels far higher than would normally be seen physiologically. Similarly, I suggest dietary calcium, cheese, dairy, meat, yogurt, as it is also the most natural way to go. By virtue of the amount of calcium contained in them, taking tablets will lead to levels of calcium in the bloodstream that are far greater than would be seen in nature, and this is probably best avoided, at least until we know more about it. As an interesting tidbit, there is some information about vitamin K2 on the horizon, and this vitamin appears to be intimately linked with calcification outside of the bones. The Japanese obtain it through natto, a fermented soybean dish. You can get it through hard cheese, soft cheese, egg yolks, butter, chicken liver, salami, even chicken breasts. The story at this stage is not completely clear about vitamin K2, and I'm not necessarily recommending it, but I think it's an interesting place to keep an eye. And there is some really interesting research that I've seen that shows if we block vitamin K, which is done through a medication called warfarin, which we use to thin the blood, a different issue altogether. But if we look at those patients and we look at their hearts, we find that people who have vitamin K blocked have higher levels of calcification in their arteries. We don't really yet know the significance of that, but keep an ear to the ground. Lastly, and I'll share this with you because it's also interesting, you can check your bone health during a coronary artery calcium score. Professor Matt Budoff has been working on validating an assessment that looks at the bone density during the time of a coronary artery calcium. So the bone on CT scan can be evaluated and can give you an idea as to whether there are problems with your bones or your bones look healthy or not. Well, that concludes this episode. Thank you for joining me. I hope you feel educated and informed, and you're looking forward to the next, hopefully not heart-stopping episode. Until next time, please don't die from a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover or a paperback and an audio from Amazon or wherever good books are sold.